Sorry, my battery's dying. Give me a
Oh
second.
God, just ruined the entire episode. Oh my God. I don't even know how I got talked into this. Like you don't even really care. Viewers are being lost. Time is just ticking. Nobody wants to see this content. Whatever. I'm going to launch into the introductions. Welcome to the next episode in our SOMU series on unintentional stay behind operations delayed or no evacuation, where Bryce and myself and many others will be talking about the different resources you can use, drugs, medications, which are both the same thing, uses of different supplies, and all those things. So anyways, if you like this video, you think it's cool, do the little thing where you press the button down there, the like button, give a comment, get the notification, subscribe. I don't know if they're in that order, but do all those things to help the YouTube algorithm so we can continue to deliver great content like this. And so I appreciate it. Thank you everyone for viewing this this video for viewing. Anyways, so I'm Josh. Everybody knows who I am. Bryce, why don't you introduce yourself so I can stop making an ass of myself?
I'm Bryce. Everyone should know who I am if you watched the first episode that we made. But yeah, at this point, I'm just a dude. I was a special operations medic for a while, got out, and I'm a teacher, and I do some humanitarian aid work sometimes. So that's me.
Yes, you do. That is you. Cool. Yeah. So like I said earlier, if you guys remember and gals remember the video before that we talked about, the little intro we did, some of the topics we were going to talk about were medications. And the first medication we're going to cover today is lidocaine, the super drug that is lidocaine. Though many may not think so, it has a million different uses outside of removing that pesky toenail or basically reducing pain when you got to get sutures. So, Bryce, why don't you, let's just kind of jump into it and, let her rip, dude.
Yeah. So lidocaine, like Josh said, there's a lot of stuff you can do with it. It can be used for local anesthesia, regional anesthesia, and something that probably most of us are terrified of doing because we were cautioned away from it is systemic pain control. So we can push it intravenously, which is going to be more the focus of this because it's what many of us are less familiar with. But we'll kind of review how lidocaine works, what are some ways we can use it, and some kind of not necessarily off-label, but less common uses for it. So first of all, lidocaine, the way it works, it's an amide, and the way that happens, whatever. Words are hard.
Latin.
It sounds like sodium potassium pumps are working. So it's a sodium channel blocker. So when you're using it locally and regionally, it'll stop pain impulses from being sent through the nerves. And that's the same as if you use it local or IV. It's going to do both of those things, or it's going to do it in both of those ways. However, when it's used IV, there's an idea that it also reduces your central nervous sensitivity. So if you are in pain, you get a nerve impulse from wherever the pain is, and your central nervous system becomes hypersensitive to it and like focuses on it, then this reduces that hypersensitivity that's created. It's one of the theories over how it works systemically.
And so, real quick, sorry to interrupt, dude. So I know that when I tried to do a lot of research on the systemic use of IV lidocaine when I first saw it, there's not a ton of research done and actually published yet on how it works and even the efficacy of its use, right?
Yeah, so it is, I wouldn't say it's like new, but it is not very well researched.
Yeah.
It's something that's grown in popularity a lot more recently because of the opioid problem that we have in emergency departments.
Yeah.
So there's a lot of research done on trying to find medications that can work for pain control that are not opiate in nature and therefore less likely to see abuse or addiction.
Yeah.
So things like ketamine use, Toradol use, acetaminophen, IV use, all those things are trying to curb our dependence on opioids. And IV lidocaine is one of those things.
Yeah. And I think, like you said,
So
it's against common practice for us. Like we've always been steered away from the use of lidocaine in a, in basic for IV use. Like it's always like, don't ever do it. You know, it's talked about, has it been reintroduced as an ACLS drug? I know it got pulled out. Is it back in as an ACLS drug?
yeah, you're definitely breaking up there for a second. I'm getting like this like heavy scowl and your audio cut out. So say that again.
I've been known for my heavy scowl. I was saying though, I was shocked when I first saw it used as an IV medication, and I was like, this is insane. And it was being used by an anesthetist who obviously knows a lot more than I do about drugs. But I know that it was used in ACLS and then it was removed. Is it put back in to the ACLS protocol?
Yeah, in the new ACLS guidelines, it's back in again.
Okay.
There's like rumors about like why that is and why it's not amiodarone, or
Yeah.
why amiodarone is not the only thing used anymore.
Mm-hmm.
Long story short, amiodarone is still an antidysrhythmic. You can still use it. Lidocaine is back in.
Okay.
Part of the complication in using lidocaine for cardiac use is it's just a weight-based drug.
Yep.
And when someone's like dead in the room and you're trying to bring them back from death, like
Yep.
it's hard to do math, so they don't like to do it sometimes.
That makes sense.
Yeah, but your dose range for that is 1 to 1.5 milligrams per kilogram, slow IV push.
Okay.
And yeah, for ACLS, like how slow it is, like that doesn't matter as much. For people who are alive that are not having cardiac problems, we want to be like very deliberate about pushing it very slowly.
Yeah.
So we can have complications by pushing it too fast.
Yeah. And I think that's kind of a general rule of thumb I think everybody should be following. I know that especially in the soft medicine realm, as medics, we get pretty comfortable pushing drugs and we want to push them fast. Obviously in ACLS, there are some drugs you do slam pretty fast. But like, yeah, but definitely try to push most of your drugs that are not ACLS and strictly told to push fast. Try to push them slow because you really don't want to be fighting with the effects. But yeah, we can talk more on the IV stuff and kind of my experience with that later. But I think the next point you're going to go into, and I think is important to note because I do have them here, is the two different that you get, the local with epi and without epi, if people can see that, with epi and without epi.
Yeah, so you got plain lidocaine and you have lidocaine with epinephrine. With epinephrine, it usually has a red label on it just to draw your attention to the fact that it has epinephrine in it. There's a lot of caution over local and regional anesthesia with epinephrine because the idea is that you can reduce blood flow to places that don't get very good blood flow to begin with, like fingers, nose, toes, and hose. Hose being penis. It just doesn't, penis doesn't rhyme with the other ones. So they had to add in another word there. But most of those things have been debunked pretty heavily. And I wrote an article about it that someday is going to get published by somebody. But anyway, it is very safe to use lidocaine with epi for regional anesthesia, even on like fingers, nose, toes, and hose. And not only is it safe, it's actually better in a lot of ways. Because when you're using that lidocaine with epi, it allows you to assess the structures that you're trying to make sure are uninjured without there being blood obscuring your view. And it'll decrease the onset by like, a minute, which is not very significant. What is significant is it'll increase the duration by like 6 times.
Yep.
So one study I was looking at, their efficacy for using plain lidocaine on a digital block was 48 minutes. But for lidocaine with epi, it was like 540 minutes.
Yeah. Yeah.
So
I think I'm sorry. Go ahead.
Oh, well, it allows us to use, the same amount of volume for a much longer period of time.
Yeah.
And we can like reduce the amount of times we have to re-inject somebody. We're providing much greater care
Yeah.
for our patients.
Yeah, I think that's important too, because I think why you see a lot of a prevalence of people steering away from the use with epi is whenever you start training people initially, you want to lower the risk of complication and possible legal ramifications of what you're doing anytime with a new you know uh, resident or even a new medic. So they probably like safest don't let people do it. But like you said, in surgical practice, in practice in general, you'll see a lot of doctors using it to help clear fields, reduce blood flow, and increase duration of the effects from lidocaine. In particular, where I've seen it being amazing is, and we were talking about this earlier, is like whenever you do a regional nerve block, which is kind of like the next step in our kind of way to provide care or provide pain relief without using narcotics, and something that special operations medics are trained to. It does the same exact thing, like interacts with the sodium potassium pumps and stops that, basically creates a blockade. Is we use bupivacaine, which is pretty awesome and has a long duration. I believe it could be up to 12 hours. Don't quote me. I'm sure somebody in the comments will fix me. But as Bryce was saying, it's hard to get. You can't really find it in most countries. So as we're talking in these resource limited areas, using something like lidocaine with epi can give you, I want to say it's 8 hours, man. And I think this is the one I was talking about, that's 7 mgs per kilogram. And when you're using it, and you can get about 8 hours of duration. So doing a regional block onto a nerve with this, which can be found in pretty much any drugstore anywhere in the world, is pretty awesome.
Yeah, because epinephrine is a vasoconstrictor, you can push more drug into the tissues without it being absorbed as quickly. So that's why you're able to get more milligrams per kilogram. With plain lidocaine, it's 4.5 or 5 milligrams per kilogram, depending on what resource you look at.
Mm-hmm.
With lidocaine with epi, it is 7 milligrams per kilogram. That's for regional blocks or local. Yeah, so
it stayed, dude. It stayed in there.
So yeah, so lidocaine with epi, you don't want to spend like too much time on it. But it is something that's easily found in a lot of places. A lot of my friends doing humanitarian aid work still, they're able to get lidocaine with epi very easily, and it's not terribly expensive either. So yeah, so a lot of utility to it as far as that goes. If we're doing systemic lidocaine use or systemic anesthesia, you don't really want to use it because you're going to run into a lot more like cardiac, just byproducts of it.
Absolutely.
Increased heart rate, increased blood pressure, stuff like that. And same thing with bupivacaine. So bupivacaine, brand name Marcaine, it's what a lot of guys know it as, what I knew it as for a long time, is it also has a lot more CNS and central vascular system symptoms to it, but you don't really want to use that for IV use. But with lidocaine, while there are still those risks, it is a lot more stable, a lot more easier to dose, and a lot more well studied than bupivacaine is, as far as that goes.
Yeah. You want to know my little tip for remembering all the different anesthetics? Lidocaine, bupivacaine, ropivacaine, Marcaine. It was taught to me in school. It's really stupid, but that's how I remember things. Is everything with a cane. When you're hurt, you need a cane. So so it's dumb. That's
dumb. But dumb things are the easiest things to remember.
That's true. That's true.
Yeah. I mean, do you remember cranial nerves?
Oh, yes, I do.
Wanted to make sure. I don't want to expand any more on that, but
there's
some really dumb ways to remember things, and it works.
Yeah, I'm sure some of our viewers who may be in the medical field know exactly what we're talking about. But anyways.
All right. So we've got for using lidocaine, we've got local anesthesia, we've got regional anesthesia during nerve blocks, and then we have systemic well, not really anesthesia, but systemic pain control.
Mm-hmm.
So when we get into the systemic use of it, lidocaine, our dose range is going to be very similar to our cardiac dose range. So 1 to 2 milligrams per kilogram is what they usually are using. What I've used in my instances where I haven't had anything better to use, and so that's what I used. I used 1 milligram per kilogram slow IV push, which is like over a minute to 2 minutes is what I have done before.
Yeah.
And then followed it up with an equal amount per hour. So
Yeah.
if I'm given 1 milligram per kilogram, let's see, Josh, how many pounds do you weigh?
120. Just kidding.
You're
150.
120 pounds. Okay. All right. So 150 pounds, quick math to convert that to kilograms. 150 divided by 2, 75, take off 10%. We're looking at like 67.5 kilograms.
Okay.
So I'm going to round to 70 because it doesn't matter that much and because it's easier math.
Yep.
So if you are 70 kilograms, and I'm given 1 milligram per kilogram, I'm going to give you 70 milligrams. So that's easy.
Mm-hmm.
And then if I'm going to keep you on a drip, then after I give you that initial bolus, I'm going to give you 70 milligrams per hour, basically forever, as long as I want to give it to you.
Huh.
And the research that I've seen done into it, they've done IV lidocaine for up to 3 days without any kind of toxic loading. So if you're familiar with, anesthesia, fentanyl is a drug that's used often for that. The more you give fentanyl, the more you run into, Josh, the word escapes me. You probably know it. So like chest wall rigidity. That's what it is.
Chest wall rigidity. Yep. That's multiple words. That's multiple words. I don't know the science Latin word you were looking for, but yes, I do know.
We can pretend that I was looking for a loftier word, but that's really all I was looking for.
And our viewers appreciate it.
So yeah, with a lot of fentanyl for a long period of time, you're into like chest wall rigidity. So it becomes harder for patients to ventilate and all that. You don't run into anything like that with lidocaine. As long as you administer it within a safe dose range, then it's going to have the same effects. Nothing's going to build up in the system. Once you stop that drip, you're looking at 45 minutes to an hour after that, your symptoms are going to come back, or you're not necessarily like your symptoms are going to come back, but your effectiveness of the pain control is going to diminish after 45 minutes to an hour.
Right.
That's when it's going to work. So relatively easy to dose. What we're usually dealing with is 1% or 2% lidocaine. 2% tends to be better for nerve blocks. So that's why it is ideal for that. Because instead of taking away pain, it does a better job of taking away all sensation versus 1%. So there's a reason to carry 2% versus 1%. Okay. But if you have 2% lidocaine, you're going to get half as much volume. And most bottles are marked with how many milligrams per milliliter that they have. Not all of them are. So if they're not, the easy trick for how to convert percentage to milligrams per milliliter is turn the percentage symbol into a 0. And then, that in addition to your, number, that's how many milligrams per milliliter it is. Ooh. So 1% is 10 milligrams per milliliter, 2%, 20 milligrams per milliliter.
Genius. And there's proof right there. I don't know if people can see that.
Yeah, that is not very well focused, but you guys can imagine what he's talking about.
It says 20 milligrams per ml.
And yeah, I've seen the YouTube trick where like you put your hand behind whatever it is you're trying to make it focus on.
Does that work?
Let's find out. Oh, it's getting so much better. It's focusing on your face. There it is. Yeah, we saw it for a brief moment. Yeah, nice. Yeah, we're in focus.
There we go. Look at that. We're learning every day.
Yep. So Josh had the 2% lidocaine, so 2%, 20 milligrams per milliliter. Awesome. So for our test patient here, which is Josh, weighing in at approximately 70 kilos, a little bit less, we're going to be giving 3.5 milliliters slow bolus, and then another 3.5 milliliters dripped in over an hour. So you can just hang that in a bag of saline, drip it in. Now your max dose per hour is 3 milligrams per hour. You should never go higher than that. I've never needed to. 1 milligram per kilogram has served me really well on the patients that I've given it to. You can get some benefits from going to 2. No one that I've seen showed any benefit of going from 2 to 3 milligrams. Okay. So might as well keep it within your parameters.
Right.
And What I do, because my ability to set a drip without a pump is I'm not super accurate. I don't think most people are. I just make sure that I don't have any more than 3 milligrams per kilogram in the bag at any given time. So that way, if someone walks by and is like, "Oh, this should be bolused in," and they open it wide open, I'm not going to kill the dude by, unfortunately, like
Yeah.
putting way more than 3 milligrams per kilogram in.
Yeah. How does that work? So whenever you start looking at the limited availability of fluids, and you know what I mean, you're trying to that could get tricky. I think that's a great trick. Absolutely. I think it couldn't that get kind of tricky though when you're like, all right, I only have this 100 cc bag. I have to make max use out of this. Obviously, I guess that's one of those things where it's like, you I don't know, deal with the
Yeah, I mean,
situation dependent, as they say.
yeah, I mean, there are really hard decisions that are made all the time, especially in the kind of medicine that we're trying to discuss now.
Yeah.
Um, but there are tricks you can use to avoid them.
Yeah.
One that I recently learned is there are pediatric infusion devices, things called Bertrol, something along those lines. Basically, you have this drip set, 60 drop drip set, and you prime it every once in a while, and then you let it run at a prescribed drip rate.
Mm-hmm.
So it's kind of like a ballast flow, and that'll help you restrict how much fluid is going through it. But if something gets messed up, it'll only drip in what you have primed it with, so that you're not going to overdose somebody by getting too much fluid into them. And
Yeah.
with peds, it's a big issue because you don't want to fluid overload them.
Yeah.
You can use it on adults in order to make sure you're not getting more than enough drug into the patient.
That's cool. Yeah, we'll have to like put that into the show notes or something. And the same thing with any of this research or anything that we find, we'll drop them into the show notes so people can, you know, read up on their own and basically come smart on it. So I guess one of my questions is I've asked this before, and I guess this is kind of a good way for me to jump in on my personal experience with it. But when I've seen it used, it was first used in the OR by an anesthetist, and I was taken back, and I asked her, I was like, I've heard all these problems with lidocaine, and she like immediately was just like, no, not true. We're using it pretty routinely now, and she was using it as one of her loading drugs whenever she was starting to put her patient under before intubation, was because it helped her with post-op pain and nausea. And I think she was actually, now that I remember, was giving in the same doses that you were talking about, and she would be giving bumps though throughout the process. Obviously, 'cause she had a million different drugs that she was working, but in between using sufentanil, by the way, another awesome drug, she was giving bumps of lidocaine to basically curb the use of all those other drugs that she was having to use and help with the post-op pain. But she couldn't really give me a great I guess a great example of what it was doing for the patient. And I think that's because, like you were saying, there's not a ton of research specifically on the mechanism of how this is working. But then what is it doing for the patient? Like, what is the patient experiencing? Like, we know with some drugs, like, you get dissociative effects, and like you could be going on a weird trip whenever you're on ketamine and so on and so forth. I've heard different things, like you kind of feel drunk, or like I don't know. What is the patient really experiencing whenever they're on lidocaine?
So I've never received lidocaine because I've never been in enough pain for me to give it to myself.
Okay.
But in the patients that I've given it to, um, most often I hear complaints of they have like a fullness in the ears, kind of like they're underwater
Mm,
after that initial bolus, tingling of the lips, stuff like that. One thing to remember is that you do run the risk of having some cardiac symptoms,
mhm,
but those happen at a much higher dose range than your CNS symptoms.
mhm,
So if you start having a guy that starts feeling drunk or euphoric, or they're dizzy, starts slurring their speech, things like that,
mhm.
that's going to be an indicator like they're at a good range, or I can back them down a little bit more.
Right.
Once you start getting past those, that's when you're running into your cardiac toxicity ranges, where you're going to run into arrhythmias and all that stuff.
Okay.
So, and for that, you can either try and reverse it with, what is it? It's lipids, a bunch of lipids, like a lipid slurry just gets injected into you.
Okay. Yep.
I know there's a better term for that. but I don't have it right now. So anyway, we'll put that in as well
We'll
later.
put that in the show notes.
Yeah, but really, really hard to find, and a lot of hospitals don't even carry it. We're definitely not going to find it in the scenario that we're hypothesizing about, which is our stay behind operations.
Mm-hmm.
So your best medicine here is going to be prevention, just not getting into that situation in the first place.
Yeah. And
beyond that, it's just going to be time,
is there,
allowing it to wear off.
sorry, we're doing the whole Zoom jump on each other stuff. Sorry. Is there, yeah, is there like an early indicator, like you were saying, the tingling of the lips, or before you get to the cardiac symptoms? Is there anything that's going to be like your early warning, like someone saying like, oh, this is happening, that impending doom or whatever it might be, and then you're like, oh shit, I should back off? Do you know if there's any of that documented, or have you experienced?
Yeah, so like I think we broke up a little bit there. So I like tingling of the lips and like fullness of the ears. That's like I've had that effect on patients where it was working really well. If anybody gets into like a euphoric or a drunken or a slurred speech stage, that's where we're getting much more of the CNS symptoms, and we want to start backing off our dose at that point.
Okay.
So if we're getting a continuous infusion, maybe back it down, by 10 or 25%.
Yeah.
And try to maintain a good pain control range without getting into those CNS symptoms, because CNS symptoms are going to present before CVS, your cardiac symptoms.
Okay. I think that's important too, because a lot of times when we're doing this medicine, you're trying to do good medicine in bad places, as they say, you don't have, like you're monitoring with your vital sign, like your BP cuffs and things like that. You may not have a good monitor to track cardiac rhythms. So we usually are titrating to effect, right? So as you're titrating, looking for those signs and symptoms, though, like keeping them between, the tingling of the lips and the euphoric feeling, I think that's probably like a good, reasonable, like you were saying, you get more euphoric, let's back off 10 to 20% and see if we can achieve the analgesic effect that we're looking for.
Yeah. And I've given IV lidocaine more than a couple times, but I haven't given it like hundreds of times or anything like that.
Mm-hmm.
But by staying at 1 milligram per kilogram, I've never had a reason to move any further than that, because I've gotten greater than 50% pain control with that dose range on a myriad of things. So I've never needed to go any higher than that.
Okay.
And I've never had any of those drunkenness or slurred speech or any of those symptoms from any of my patients.
Okay. Cool. No, I think that's awesome.
Some of the things I have treated since I've talked about some patients, rib fractures. It's been really effective for that. Had a guy who he's actually a student of mine that I was trying to teach, and he had broken his ribs trying to do some pull-ups and just like fell on his back and just totally ate it. So he had like a posterior rib fracture that was super painful for him. Put an SpO2 on him. His SpO2 was sitting in like the mid to low 90s, just because he wasn't able to ventilate super great. His posture was terrible. I would try and crack jokes with him, and it would just be super painful and all that stuff. Because maybe I'm just not a good person. I don't know, but it's
terrible bedside manner.
Laughter is the best medicine in most cases. For rib fractures, it's probably not. So yeah, but this guy was also like in the medical community as well. So he was very interested in what was going on. So we were just doing some experimentation. So he weighed about 80 kilograms. So I gave him 8 cc's of 1% lidocaine, slow IV push. And then I hung another 80 milligrams in an IV bag, and we dripped it in over an hour.
Okay.
So his posture improved. His depth of respirations improved. His respiratory rate decreased. His SpO2 went from like low to mid 90s to like 96, 98. It was a huge benefit for him. And his pain scale went from an 8 out of 10 that was sharp down to a like 3 to 4 out of 10 that was dull. So it was a really, really good pain reduction for him. And he's like doing all this like range of motion stuff. He was like, yeah, that doesn't hurt. That doesn't hurt. It's like twisting around. And it wasn't until after we stopped the infusion and he got in his truck and drove away, getting out of his truck, all of those motions he had made that he wouldn't normally have made caught up to him. And he was in a ton of pain after that. So that can demonstrate like maybe if you're experimenting with it, don't have them do anything they wouldn't normally do. I've seen this a lot with like intra-articular injections. Like people have a knee pain or whatever, you give them like a Kenalog shot. Tell them not to do anything that they wouldn't normally do because they don't feel the pain that they're creating in themselves, and they're like potentially causing damage. So, but anyway, so it was like very, very effective for that patient. First time I ever gave it to someone was a young woman, fell off a motorbike, broke a leg. I had some ketamine. I had access to some ketamine,
Mhm.
but I didn't want to use it because we were trying to save it for like emergent procedures that may happen. We didn't have very much of it. So I'm like, hey, I've heard about this lidocaine thing. Like, let's try it out. So she was tiny. She was, maybe like 40, 50 kilograms. She was a very petite person.
Oh, wow.
And so I gave her 4 cc's of 1% lidocaine. Same thing. I was working through a translator. Her pain scale went from an 8 out of 10 down to a 4 out of 10. She didn't give me like a quality of pain that wasn't translated very well.
Right.
But we were able to set the bone and everything with minimal patient discomfort. And then someone asked me like, okay, like how do we redose it? And I couldn't remember. So we just dipped into our ketamine and gave them some of that.
Yeah.
um, so it's nice to know like what, not just what your initial dose is, but what your follow-on doses are.
Yeah.
And being comfortable with that so that you can do the most good for your patient without being afraid of, hurting them. Because I was terrified. That was my first time using it. I knew there wasn't a ton of research on it. I knew that it was supposed to work, but I didn't know, what my window was between like good pain control and then murdering somebody with bad medicine.
Yeah.
So
Yeah.
I was being hesitant.
That's a difficult situation, especially like you're put in this situation where you have no better choice really. Like you did have the ketamine, but again, you're limited on resources. Maybe a broken leg isn't as high on your triage list as the trauma patient that may come in 10 minutes. So I guess like yeah, having that, like this is the whole reason we're doing this series, having that tool in your aid bag to be like, oh, I could do this. But like you said, another reason why we're doing this series is so people can come better educated on it and then do the research themselves, because a lot of this stuff, correct me if I'm wrong, is both you and I and other people just going out and trying to find the science and finding the research on it and doing it ourselves, because this isn't something you're going to open up a textbook and you're going to immediately find written out the use of this. It's basically environmental based medicine where we're going out and we're doing these things because we have no better choice. But that being said, the whole point here is to basically do no harm. You're trying to do what's best for your patient. So definitely take cautions. Be precautious whenever you're doing this. And I should just put this out now. I should have done it at the beginning. This is a full disclaimer. This is no replacement for your own your institution's best practices or their guidelines or strict rules or regulation. This is by no means us saying this is how should be done. This is us giving you a basically some suggestions that we've learned, but do not replace any of your organization's practices or take this as gospel. This is purely us putting out information. Please do the research and don't hold us liable.
Yes, please don't hold us liable. I'm no doctor or anything. I still have some credentials, but like I said, I am no doctor. And yeah, this is something that I have researched a lot out of necessity. It's not something that you should use if you have better options.
Yeah,
so,
absolutely.
But with that, so I've talked about some anecdotal experiences of my own. I've used it on rib fractures, leg fractures, hand fractures, minor frag, things like that, and it's worked really well for me in the past. But let's look at some of the research. So there's a couple papers that we'll put into the information below. One of them is by a gentleman named Hassan Solimanpour on the effectiveness of IV lidocaine versus morphine for patients with renal colic. And so the doses they were giving was 1.5 milligrams per kilogram, just a single dose. They weren't doing any drips or anything after that. And they were comparing that in a blinded trial to morphine at 0.1 milligrams per kilogram, single dose. And so they were checking the patient's their visible assessment scale. I think that's what VAS stands for. It's a pain scale, 0 to 10 pain scale that we're all familiar with. Before and after injection, and at 5 minutes post-injection in the lidocaine group, their pain score was reduced by 65%. And in the morphine group, it was reduced by 53%. So it actually was more effective than morphine in that particular trial at 5 minutes post-injection. And I mean, you can argue that morphine, the onset isn't going to be as fast as perhaps lidocaine could be. So at 5 minutes, it's not like the best indicator right there. So study number 2. This one is comparison of intravenous lidocaine versus morphine in critical limb ischemia. And the primary researcher on this one was a guy named Elnaz Vahidi. So for this one, their dose range was 2 milligrams per kilogram of lidocaine. And for the morphine group, it was still 0.1 milligrams per kilogram. They were also doing initial boluses plus a follow-on drip after that, if memory serves correctly. So they did a pain score before 15 minutes post-injection and then 30 minutes post-injection. And the lidocaine group versus the morphine group in their pain assessment scores prior to injection were 7.5 and 7.65 respectively. So very, very similar. At 15 minutes post-injection, the lidocaine group was 5.75 and the morphine group was 7.0. So some very good results there for lidocaine. And at 30 minutes post-injection, lidocaine pain score was 4.25 and the morphine pain score was 6.5. So we're seeing consistently better results when compared to a weight-based dose of morphine in 2 studies there. So, and like I said, there's not a ton of research out there. Those are 2 studies that I found this morning. There were a few trials that were done before. I'll try and find the paper where they were looking at non-opiate pain meds for the emergency department. And they had really good results with IV lidocaine. There was one very notable overdose that they had where the attending was not familiar with the protocols. And so instead of ordering 100 milligrams of lidocaine for their patient, they ordered 100 milliliters of lidocaine for their patient. So they ordered 10 times as much.
Yeah.
And for any, medical provider, practitioner that may be listening to this, if someone ever asks you to draw up multiple bottles of a drug to give to somebody, that is an indicator maybe you should confirm their order.
Yeah.
So after this this poor nurse had drawn up 4 bottles of lidocaine to give to their patient, patient began to code. They began CPR, and again, if memory serves, patient ultimately survived. I don't recall at this time if they were able to use the slurry of lipids to try and reverse it, or if it was just time and CPR that kept this patient alive. But nobody died of lidocaine that was not dead already in that study.
Yeah.
So
I think
too long didn't read working. Sorry, you got something to say, Josh?
No, I was saying I think that's huge. There's a lot of good points in that, especially like I think you've done it before, but like even those who are not as well versed in medicine, whenever you look at assistants and non-medics, like if you're drawing up multiple vials of something, you may want to just repeat or ask, hey, you do want me to draw up all of these, or do you only want me to draw up one of these? Like, which one is it? Because it's you don't want to be that person for sure. But no, that's awesome. I think you hit some good points on that too. As the duration went, the effects were either consistent or better with lidocaine versus morphine, because I've used morphine in the past for patients that were going on a long trip, and IM morphine is kind of great for that, for the duration of 8 hours or so, to give you some some pain control as they go on to their next level of care, and you don't have the best provider there, but you run that risk of, if I give too much, they're going to have respiratory compromise. So that's why I
Yeah.
always chose, like, given like 10 IM, because I know that that's not going to, it's going to be a slow uptake, and they're not going to lose respiratory um, drive with that. But with lidocaine, I think that's awesome that you can get a long duration and you don't get those respiratory um, compromise effects out of an IV medication. So that's
Yeah.
pretty dope.
A little tangent off of that, using like hydromorphone or fentanyl subcutaneously as opposed to IM can also give you really good pain control for a very long duration.
Heck yeah.
So there's some stuff for all of our viewers to read up on and not just rely on me saying things.
Look at all those tips, dude. We're all about it here. All of that. Come to the SOMC YouTube videos and get all the tips and
Yeah,
tricks.
I love those little things because those are little things that they allow you to treat your patients better, but also they win you a lot of rapport when you can do little things that have huge impacts.
Yeah.
Like I have students all the time that like, someone cuts their finger while they're doing a trauma lane or whatever. And they're like, oh, you got a Band-Aid? And they're like, oh, I don't carry Band-Aids in my aid bag. Like deal with it.
Yeah.
Yeah. But if you're, infantryman or, whoever else you're working with has a cut on their finger and they go to you for help and you tell them to walk it off and quit being a little pansy,
Yeah.
then like they're not going to appreciate that very much. If you can just give them a Band-Aid that takes up no space in your aid bag, then they're
Yeah.
going to appreciate that a lot. So
Yeah.
it's going to make them want to help you more in the future
Yeah.
instead of telling you like, oh, well, deal with it, dude. You'll be fine.
Well, I would also say is I kind of I'm on the fence of those, because sometimes like it gets annoying when people come to you with that. But what I've done to kind of mitigate that is I've made little, like, the drug baggies full of Band-Aids, bacitracin, and some iodine, and I'm like, here you go, this is yours. Here's your little boo-boo kit. Keep that in your shoulder pocket, and if you need one, you got one. But I do keep a couple Band-Aids just in case. And even the local national, or the host nation person, or the local force or humanitarian assistance that you're giving, if someone walks up and they're like, I have a cut, you don't know who that person is. That could be the village leader's kid or something. And
Yeah.
you give them a Band-Aid. And actually, I may post a picture of doing something like that. It actually gained us some pretty big rapport. Just giving a kid, I think I like rebandaged his toe that had like a cut on it or something, and we were able to have a place to sleep that night. So, um, it can definitely win you some brownie points.
Yeah, it's huge. Like some of the things I appreciate most from my deployment experience have just been the little stuff. Like there was one mission went on where we were supposed to land one place and we did not land there, and it was like super high altitude and really cold, middle of the night in the winter, and it was just terrible, terrible, terrible. No one is dressed for moving really fast through like really rough terrain, so everyone's like pouring down sweat. So once we get to where we were going, everyone was freezing cold, and it was just a terrible, terrible mission. Well, one guy that wasn't on that mission, his name was Caleb. Awesome dude. He showed up when we got back from that mission with a tray of hot chocolate.
Oh
And
god.
that was the best hot chocolate I've ever had in my entire life. And
Oh,
I love that man because he gave me hot chocolate one time. So, like, it's little things can be very impactful for the people that you're working with, and they can make everything way better.
absolutely.
Yeah.
Absolutely. I think we kind of went on a tangent, but that was very important.
Yeah.
Yeah.
All right. So I think it's time for the too long didn't read version of IV lidocaine. You
Yeah.
agree, Josh?
Yeah. No, I think that is. Yeah, absolutely.
All right, cool. So skip to this part of the video if you don't like hearing a bunch of random stories and background information. So dose range for IV lidocaine, we're looking at 1 milligram per kilogram slow IV push. And that's over 1 to 2 minutes. It's not like your make believe slow IV push where we just like don't slam it. This is like a legit 1 to 2 minute bolus. After that, you can do a continuous infusion at the same rate, 1 to 2 milligrams per kilogram per hour. And you can do that basically indefinitely, so long as you don't go any more than 3 milligrams per kilogram per hour. 3 milligrams per kilogram per hour is your absolute max dose per hour. Once you get higher than that, you run real risk of having cardiac symptoms. So cardiac symptoms are going to happen after your CNS symptoms. So if your patient starts getting drowsy or having slurred speech, feeling drunk, feel euphoric, dizzy, any of those types of things, then that's going to be a good indicator to reduce your infusion rate. What you're likely to see is fullness of the ears, tingling of the lips and tongue. That's all okay. They're not dying if that happens. That's what you should expect. So, and as far as pain reduction goes, it should be about 50% pain reduction. I've had better than that in some cases, and I've had right about 50% pain reduction in other cases, but I've had good reduction in pain every time I've given plain lidocaine. So anything to add? Any questions from that, Josh?
No, I think that's actually perfect, and I'll put a timestamp in the show notes so people who don't want to hear us rant can just jump to that for reference. But
so when they're like looking up how to save somebody in their garage, they can just like quick go to that.
Just quick. Oh my god. Oh my god. Again, don't do this in your garage. We are not replacing your. We don't hold us liable, man.
Depending on where your garage is, I would say.
Yeah, exactly. Maybe someone else's garage overseas, bad times. You're trying to do good medicine. I get it. All right, cool. I think the 50% reduction in pain is important to note, because a lot of times what we forget when we're using analgesia is we're trying to achieve an analgesic effect. Basically, you're not trying to take the pain completely away. You're trying to manage the pain and have your patient be able to manage the pain so that you can treat this patient, because pain is a good indicator. Like you were saying earlier, pain is a good indicator of what you should and should not do. Especially if you take pain completely away, you run the risk of causing further injury. And then you may take away drive at some point, depending on how deep you go down the rabbit hole with this. Sometimes, the pain is it's hard to state, but especially as healthcare providers, we always want to like completely alleviate all our patients' pain, put them in the best scenario possible for them to live. Well, our job is to reduce the effects of that pain so that they can manage it, especially if you're dealing with like a musculoskeletal injury or something like that. But more so if you're dealing with a trauma patient who's trying to hold on to life. Let's not try to completely take away all pain whatsoever until we've gotten through all of our treatments and we know that this patient is going to be able to be stabilized long term by a higher healthcare skilled practitioner. I guess is the best way to say it. Cool. Yeah.
All right.
That's all I got, man. I think that's awesome. Great first video. You got anything else you want to add to that?
No, I don't think so. Just one more caveat that this is not like your standard of medicine. This is some emergency stuff. And the reason why this can be really helpful is lidocaine is everywhere. It's easy to get. It's very inexpensive. And if you're in a situation where you can't get ketamine or don't have very much of it and you want to save it for more important things, then it'll be really good for you. Of course, there are better things to give than lidocaine, but lidocaine, in my experience and in a few studies that you can find online, has been found to be very effective. So it's another tool for the toolbox.
Absolutely. And that's what we're all about. And join us again next time when we have more of these videos, and we're going to keep this train rolling because I think this is an awesome topic, and I'm sure everyone out there has an opinion and wants to see some more of it. So if you do, hit us in the comments section and please let us know what your opinions are or what you would like to see some more of. You may know of a cool topic that we could cover here in these videos, and in the future we'll try to get some more people in, so it's not just Bryce and myself sitting here rambling about what we think is the best practice. Maybe we'll get someone who's got a little more experience or a different experience who can lend some help to that. So hit the little button things we talk about, the like, the notification, the subscribe thing, comment, do all those things. But yeah, that's pretty much what I got. Please hit us up at www.som-c.org to find out how you can help your military special operations medic and keep this train rolling. And yeah, that's all I got. Thanks, everyone.
Thank you all. See you next time.
Bye.
Bye.